Good afternoon. My name is Victor Van Berkel, and I'm one of the thoracic surgeons at the University of Louisville. This lecture, recorded at the end of 2011 for the TSDA curriculum, is intended to serve as an introduction to lung transplantation. Here is, very briefly, what we will be talking about today. We will start with a short history of lung transplant, examining the rapid rise of the procedure over the last 30 years. We will look at some recent statistics about the numbers of transplants being done today and who they are being done to. We will then have a quick overview of the characteristics that make someone a good potential recipient for a lung transplant and use this as a means to talk about the lung allocation score. We will look at the factors that go into deciding when a donor has acceptable lungs for procurement and then talk very briefly about the operative technique. While there is no consensus about the optimal immunosuppression regimen for lung transplant, there are several generalizations that can be made, which we will outline. We will look at the outcomes after lung transplant and see that we have an opportunity to improve a great deal. And finally, we will finish by looking at some of the exciting new data that has come out in the last year and how it will affect the field of lung transplant. First, a little history. The first human lung transplant was performed in 1963 at the University of Mississippi. Interestingly, the recipient was a 58-year-old male with a history of heavy smoking and emphysema who had a bronchogenic carcinoma occluding the left mainstem bronchus. The donor lung was removed from a patient that had died from a massive intracranial hemorrhage. The patient survived the operation, but ultimately expired 19 days later from renal failure and malnutrition. Over the subsequent 20 years, approximately 40 patients underwent lung transplantation at various centers around the world, with no long-term survivors. Most patients died within 2 weeks of the operation as a result of either primary graft failure, sepsis, or rejection. The most frequent cause of death after 2 weeks was bronchial anastomosis dehiscence. In 1981, the Stanford group reported on a successful combined heart-lung transplant on a patient with idiopathic pulmonary hypertension. Finally, in 1983, the Toronto Lung Transplant Group, led by Joel Cooper, performed the first successful single lung transplant on a 58-year-old male with idiopathic pulmonary fibrosis. The first double lung transplant, performed for emphysema, was performed also in Toronto in 1986. The success of these later attempts was largely attributed to improved surgical technique, as well as the advent of cyclosporine, which permitted a drastic decrease in the amount of steroids that were used for immunosuppression. Since those humble beginnings, lung transplant has grown by leaps and bounds. Here is the most recent data from the International Society of Heart and Lung Transplant database. These slides are freely available at their website, the web address of which is listed on the slide. From the single-digit number of transplants performed per year at the beginning to over 3,000 transplants reported to the database in 2009, there has been tremendous growth in the practice of transplantation. Interestingly, over the last 15 years, this growth has been driven by an increase in the double lung transplants, as the number of single lung transplants has remained relatively stable. So who are getting these transplants? The pie chart on the left represents the single lung transplants performed over the last 5 years. You can see that the majority of single lungs are done for COPD or idiopathic pulmonary fibrosis. Very few single lungs are done, understandably, for cystic fibrosis or pulmonary hypertension. The double lung transplants, on the right, are split fairly evenly amongst COPD, cystic fibrosis, and pulmonary fibrosis. The other category here includes a wide array of ailments, with the notable ones being sarcoidosis, bronchiectasis, and congenital heart disease. The percentage of patients receiving a transplant for pulmonary fibrosis has been steadily increasing over the last several years, largely due to the effect of the lung allocation score, which we will discuss in a moment. This is another graph looking at the indications data. This graph demonstrates the number of transplants, either single or double, done each year, with each color representing a major indication. The first thing to notice is, once again, the rapid growth in the number of transplants being done. The second is while there has been an increase in the number of transplants being done for COPD and cystic fibrosis, there has been a disproportionate increase in the number of transplants being done for idiopathic pulmonary fibrosis. The ATS and ISHLT have released guidelines regarding what patients should be considered for lung transplant. Of course, the primary reason to consider transplant is because of severe pulmonary disease that is refractory to medical treatment. Because of the limited longevity of lung transplants, only patients with a limited life expectancy due to their disease should be considered. For consideration, patients must be of a reasonable age. The stated guidelines are less than 60 years old for a bilateral lung transplant and less than 65 years old for a single lung transplant. The rationale for these limits is that recipients older than 60 have a shorter survival than younger patients. While older age is not an absolute contraindication, multiple comorbidities can combine to increase the risks beyond an acceptable threshold. It is worth noting, however, that in 2004, fully 20% of the transplants done were on patients greater than 60 years of age. Multiple studies have identified pre-transplant obesity as a significant risk factor for mortality post-transplant, and the ATS guidelines recommend delaying listing patients until they are able to get to within 20% of their ideal body weight. While it can be difficult to assess, it is important that the patient have the support mechanisms needed to ensure adequate postoperative care of their lungs. And, as unpalatable as it is to bring money into a discussion of patient care, transplant medications are expensive, and care must be taken to ensure that the patient will have adequate coverage to ensure continued access to their medications. There are a few medical conditions that serve as absolute contraindications for consideration of transplant. Having a malignancy within the last 2 years, untreatable organ dysfunction other than the lungs, or a non-curable extrapulmonary infection, most commonly hepatitis B, hepatitis C, or HIV, all would render a patient ineligible. An inability to cooperate or comply with therapy, or the lack of a sufficient support structure would also prevent a patient from being able to be listed. Finally, evidence of substance addiction, most notably tobacco use, within the last 6 months would serve as a contraindication to transplant. Once the patient has completed their evaluation and a center has accepted them for transplantation, they are placed on the National Lung Transplant List, which is managed by UNOS, the United Network for Organ Sharing. The position of the individual patient on the list is determined by something called the lung allocation score. Historically, a patient's position on the list was determined by their waiting time. This led to the unfortunate situation of many sick patients dying while on the list, which led to programs placing patients on the list well before they were appropriate for transplant, in an effort to have them near the top of the list when they became sick. To fix this problem, the lung allocation score was devised and put into place in 2005. It is designed to get organs to the patients in whom it will do the most good, taking several factors into play. These factors are balancing the urgency of the transplant, or how likely the patient is to die without a transplant, with the patient's likelihood of a good outcome after transplant. Several physiologic parameters are used to give a raw score, which is then normalized to a score out of 100, with a higher score representing a higher position on the list. As a reference, the average score of a transplanted patient in the United States in 2009 was 43. Once we have determined who should be getting new lungs, the next challenge is determining if donated lungs are appropriate for transplantation. Finding acceptable lungs is a challenge. Unfortunately, whatever process leads to an individual becoming an organ donor usually results in an injury to the lungs. Nationwide, only 15 to 20% of organ donors have lungs procured because of this problem. The ATS and ISHLT provided a consensus statement describing the ideal lung donor characteristics. They include blood type compatibility with the recipient, age less than 55 years, a clear chest X-ray, a PaO2 of greater than 300 on 100% FiO2 and 5 of PEEP, a tobacco history of less than 20 years, a clean sputum gram stain, and an absence of purulent secretions, chest trauma, or aspiration. You can appreciate that it is incredibly rare that an organ donor is going to fulfill all of these characteristics, and indeed, a database review done by the Cleveland Clinic, published in the Annals of Thoracic Surgery in 2010, demonstrated that most of the time, lungs are accepted from donors that do not fulfill all of these characteristics. The transplant operation itself is relatively straightforward. A single lung transplant is typically performed via a standard posterolateral thoracotomy, while a sequential bilateral transplant can be performed with the patient supine via bilateral anterolateral thoracotomies. If additional exposure is needed, or cardiopulmonary bypass is required, the bilateral anterolateral thoracotomies can easily be extended to a clamshell incision by dividing the sternum, greatly improving access to both hilums and the great vessels. Care must be taken during the explant procedures to preserve the phrenic and vagus nerves and to prevent skeletonization of the recipient bronchus. The new lung is sewn in place, performing anastomoses from posterior to anterior, bronchus first, followed by the pulmonary artery, and the pulmonary vein to left atrium anastomosis. In an effort to improve blood flow to the donor bronchus, there was a period where bronchial artery anastomoses were favored, but this practice is no longer common. Keeping the donor bronchus to a minimal length, usually approximately 1 ring above the lobar cariner, and maintaining the parabronchial lymphatic tissue is critically important to minimize ischemic injury to the bronchus. The length of the donor bronchial artery must be carefully trimmed to ensure there is no kinking of the artery once the lung is inflated. And finally, during the left atrial anastomosis, which provides pulmonary vein drainage, sewing cardiac endothelium to cardiac endothelium is emphasized to minimize the risk of clot formation along the suture line. One important variable with regard to the operative procedure is the use of cardiopulmonary bypass. Aside from patients with known pulmonary vascular disease who will need to go on bypass, it is difficult to predict, based on the patient's preoperative profile, whether they will need cardiopulmonary bypass or not. During the operation, refractory hypoxemia or unstable hemodynamics typically occur at one of 3 points: after clamping the pulmonary artery during the first transplant, after perfusing the first allograft but before starting the second transplant, or after clamping the pulmonary artery during the second transplant. Bypass should always be available should instability occur at any of these points. There are some surgeons who feel that every transplant should be done on bypass, regardless of hemodynamics. The stated advantages include being able to offload the heart during a physiologically challenging operation, as well as having lower pulmonary artery pressures during initial reperfusion of the allografts, which may lead to less reperfusion injury. Especially in patients with relative cardiomegaly, decompressing the heart can make the left atrial anastomosis substantially easier to perform. Use of bypass does have some disadvantages, of course. The potential complications of a pump run, adding some operative time due to the need to go on and come off bypass, and bleeding associated with the obligate heparinization. This can be a particular concern in patients with challenging explants, such as a pulmonary fibrotic with a history of open biopsies, or an emphysematous patient who has undergone pleurodecies. Of course, once the transplant is done, the work for the patient is just beginning. As with any organ transplant, an aggressive medical regimen is required to prevent rejection of the organ. For lung transplants in particular, because of their constant contact with the outside world, balancing these medications to prevent rejection, but still allow the body to fight off infections, is a perpetual struggle. While there are some commonalities amongst the types of medications used, there is wide variance between programs regarding the specific details of regimens. For the most part, there is little data to support one regimen over another. In broad strokes, most patients are treated with a calcineurin inhibitor, an antiproliferative agent, and steroids. Cyclosporine was the classic calcineurin inhibitor used, although tacrolimus has largely supplanted its use. The levels of these drugs must be carefully monitored, as their metabolism can be affected by several other drugs, and they have significant nephrotoxicity. Azathioprine, or its trade name Imuran, and mycophenolate mofetil, with its trade name Cellcept, both act as anti-lymphocyte proliferation agents. Their major side effect is leukopenia. Finally, patients are typically started on steroids, but for those who do well, the steroid dose can be tapered down, or even off in some cases, once in the maintenance phase. There is evidence that the use of anti-lymphocyte antibodies during the induction period decreases the frequency and severity of acute rejection, although the use of these agents depends quite a bit on institutional experience and preference. With all these transplants being done, what are the results like? Here is the composite survival curve from the entire ISHLT database, showing that the long-term survival for lung transplants is not spectacular. The half-life for single lung transplants is a little under 5 years, while the double lungs do better, with a half-life of almost 7 years. There are several important points to be made about this graph, the greatest of which is that this is obviously a gross oversimplification. Of course, there are subgroups that do better and subgroups that do worse, but the overall point remains that transplant is not, for most people, a treatment that provides long-term survival. Given that the life expectancy for most patients awaiting lung transplant is less than 2 years, however, this 5-year window still represents an improvement. Their survival advantage is not the entire story, of course. This graph examines the functional status of surviving recipients over the first 5 years after their transplant, and demonstrates that over 80% of lung transplants, after their post-operative recovery, are able to perform their activities of daily living without any limitations. This is in stark contrast to their preoperative state, which typically has them tethered to an oxygen tank and unable to do much of anything. While the overall mortality benefits for most patients is modest, there have been numerous studies that have documented overall improvement in quality of life after transplant. Indeed, one study out of Germany found comparable quality of life results between lung transplant recipients and a normative sample of healthy people. Ultimately, this improvement is what we are hoping to offer people. Finally, I would like to close by mentioning a study that will likely be changing how all of us operate in the years ahead. In an effort to improve the number of lungs usable for transplant, Dr. Shaf Kashavi's lab in Toronto has been championing ex vivo lung perfusion, taking marginal lungs, isolating them from the donor, and placing them on a ventilation and perfusion circuit. Once on the circuit, the lungs can be rehabilitated, pulling off edema, treating infection, or actively treating with anti-inflammatory agents. Dr. Kashavji's lab, earlier this year, published a series of patients where they took lungs that would have otherwise been rejected, rehabilitated them ex vivo, and then transplanted them, with excellent results so far. This technique could increase the number of available lungs from the 15 to 20% of organ donors we mentioned earlier, up to 40 to 50%, which would be an incredible boon for the patients waiting on the transplant list, and something that we are all obviously very excited about. Thank you very much for your attention during this lecture, and please feel free to contact me with any questions that you may have.